You can see from this list, we have quite a bit of material to get through in our short time today, but there will be ample opportunity for follow-up, and you're always welcome to send us any questions on email. Our contact information can be found on the last slide in this deck. These slides in this recording will also be posted on our website within about a week or so of the live event, and we'll send out an announcement once the materials from today have been posted. So our first item is an overview of the why. Why are we implementing this new performance program? HPSM has had a pay-for-performance program for approximately the last 10 years, and while there have been several changes, the overall structure has largely remained consistent. One patient, one service, and one bonus payment. So we're shifting how we view performance from a single patient and single service to looking at performance across the whole person and the whole population. Many of these measures will be very familiar to you, including BMI, depression screening, and others, and you may even be familiar with this program structure for quality thresholds from other payers that you contract with. This is new for HPSM, but it's largely not new for the healthcare industry overall. We see this program structure as a natural next step to the performance program that we've had in place, and we believe it will benefit our provider community through increased data sharing and earn potential, while benefiting our members by taking the whole person and population health perspective. So now we'll talk about some of the program highlights. So this year is a baseline year, so we're only calculating performance based on designated quality thresholds, and we'll go over more information on those in just a few slides. This year, each participating clinic will be paid based on performance of 7 quality metrics. 3 of those 7 metrics will be assigned by HPSM depending on the patient population age range for your clinic, so whether it's an adult clinic, a family practice, or pediatric clinic. 4 of the additional metrics will be chosen by your clinic from the remaining performance measures in this year's program, and those are also outlined in just a few slides. All right, so some additional highlights. You'll see all of the measure source information shortly, and most of our P4P measures are NCQA HEDIS measures, and for those we're using the 75th percentile benchmark for our full credit quality threshold this year, and the 50th percentile benchmark for the partial credit quality threshold. Several of the measures in the program are HPSM network specific, and we've set our own baseline quality thresholds based on prior year network performance and quality goals. And since this is a baseline year, we do not have improvement targets, but those will be built into future program years. Are there any questions about that?
Understood. Okay.
Oh, Vicki Perez.
Okay. All right. So one of the benefits of this new program is that you'll not need to submit the P4P procedure codes that you have to send us under the fee-for-service program today. That is because these performance payments will not be paid through claims. The regular procedure codes that you send to us will be counted in the numerator for your assigned patient population. We will calculate your progress quality thresholds, and you will receive monthly progress and member-level reports so you can see exactly how you're doing and who you need to do outreach for. This is different from some other programs I've seen in the sense that we're not using self-reported data from clinics, and this is because one of our aims is to reduce the administrative burden for participating in this type of program. Additionally, your performance will be calculated based on the absolute quality thresholds for this baseline year. We're not scoring performance on a curve across the network, which is also something that we've seen in other programs. So what this is that you're competing only against yourself, quality thresholds, not your peers. However, at some point in the future, we do plan on sharing relative network ranking reports for informational purposes only. So in this program, you will receive monthly reports. You'll know exactly which patients we have lab data for. And we did want to share with you the 4 sources of lab information that we have right now. These are the 4 organizations that send us monthly lab data through files. And so we are reaching out to several of our partners to see how we can streamline the lab data sharing so that we can increase the sources that we receive this data directly from. So if anyone has questions about this or would like to see how you can set up lab data sharing processes with us, please reach out to us after today's webinar. Also, on the May 2nd P4P reports that are in e-reports, they'll be posted next week. You'll see exactly which patients we have lab data for in your clinic. And sometime in May, we're going to have another webinar to go over those report structures. So for now, we encourage you to familiarize yourself with logging into e-reports and getting your staff access to those reports and just viewing the various new reports that we've posted. Are there any questions on that?
No.
Okay. All right. And again, if people could just quickly check that your phone is on mute if you're not asking a question, that would be great. Okay. So how does this program relate to the overall payment model updates that we've been discussing? Many of you have probably seen this slide before, so I'm not going to go into a ton of detail on the information here. If anyone has not seen this information before, please reach out to me after today's webinar so we can set some time to review it with you. And look out for our provider newsletter soon that will also outline the information shown here. And the main point of showing this today is that providers who are on track 3 of our new primary care Medi-Cal payment model will be eligible to participate in the benchmark P4P program that we're going over today. So as a brief review of what this slide is showing, these boxes on each track are not exactly to scale, but they are different to indicate differences in level of potential payment based on the track that you select for July 1st. Providers that participate in the benchmark P4P program will have the potential to earn more performance bonus dollars under this program than under the fee-for-service program. The key is that those dollars are held to meeting the quality benchmarks. So there is some risk involved in participating, but again, there's also a greater earn potential. And we'll talk more about this in just a few minutes, but again, we will be providing you with additional data as you go, so you'll know exactly where you stand in terms of your progress in the program. Okay, so now we will do a deeper dive on some of the program components. So here's the full 2018 benchmark P4P program measure set. There is quite a bit of overlap with this, with our fee-for-service program, but there are some new measures and some differences in the way that we will calculate these. Anything that has an asterisk next to it is a health plan targeted measure, so depending on your patient population age range, you will get assigned 3 of these targeted measures from the health plan, and again, you will select 4 additional to come to that total of 7 quality measures for this program year. So now we'll go over an example clinic for measure selection and what that will look like. So here's an example of what the measure set might look like for a clinic starting in July. These measures would be geared towards a clinic that sees adult patients. And in order to be assigned or select any of the program measures, your clinic must have at least 30 patients that meet the denominator criteria. And that's so that there's a large enough sample size to give you credit towards those benchmarks without there being wide variation in how you'd be measured on performance. So in this example, the clinic was assigned the encounter threshold, the diabetes HbA1c control, and cervical cancer screening. For the additional 4, they chose adult BMI assessment, initial health assessments, diabetes retinal eye exam, and mammogram for breast cancer screening. Most measures on this list are HEDIS measures, except for the encounter threshold and initial health assessments. Those are HPSM network-specific measures and have network-specific benchmarks. Again, if the measure is a HEDIS measure, we are largely using the NCQA HEDIS measure definitions, and for this program year's benchmarks, we're using the 50th and 75th percentile for partial and full credit, respectively. I'm going to pause again to see if there are any questions on that.
I'm sorry, I'm late for the meeting. On what page are we currently at?
Are you able to view the screen by any chance, or are you listening in?
I'm not. I'm just dialing in. I should go online?
Yep. So in the email sent out just a little bit ago this morning, there should be a link so that you can follow along with the slides.
Yes. Okay. Thank you.
Okay. And we'll also send the slides out after the meeting today. They'll probably be posted sometime within the next week or so.
Okay. Thank you.
Okay. All right, so now we're going to talk about several new reports that HPSM will provide to support your participation in the program. You might have already heard from us about several other new reports that are available today, including the current P4P and panel engagement information. We're not going to cover those today, but again, we're planning a webinar for sometime in May to review how to use those reports. And just another reminder, if you don't currently have an eReports login, please reach out to us, and we can also get your staff set up with logins as well. So here's an example progress report based on the 7 measures that example clinic was assigned for payment. One thing that will differ on the real progress reports that you'll receive is that you'll have information for how you're doing on all of the measures listed in the full measure set. It's just that your payment will be calculated based on the 7 measures that you're assigned for this year. This example is for a clinic that has 225 patients assigned, and this was run for the month of March, so we're only 3 months into the program year. Keep in mind that since these are annual benchmarks, you're likely to have lower scores earlier in the year since fewer patients have come in throughout the year so far. Right now, this clinic has a total quality score of 0.86, so they are just over 40% of the way to their full credit quality score. And that's pretty good because since it's run for the month of March, that's only about 25% into the program year. This might sound complicated, but that's just because I'm throwing in all these numbers and percentages for this overview, but the bottom line is that you'll receive the progress each month along with the patient-level information for who falls into the numerator and denominator categories. We're going to do all of the tracking based on claims information that you're already sending to us, and we'll do the calculations for you based on your progress. So all you need to do is review your patient lists, conduct the outreach based on these reports, and send us the encounter data for the services that you're already providing. And this color coding is also just for visualization, so anything that's in the light red is below the partial credit benchmark. Anything in orange under that current progress column, it's still below the partial credit, but it's getting closer. Anything in yellow is between partial and full credit, and anything in green is over full credit. Also, the number of average member months is the average count of the total population multiplied by the number of months in this year. So for this clinic, it's based on a practice that has 225 patients assigned. So for 3 months, they're at 675 average member months so far this year. So that was a lot, so I'm going to pause again to see if there are any questions.
Katie, this is Evelyn from Ravenswood.
I do have a question. What about new providers that are coming in?
You said
what
they're
are we going to work off of if
Sorry,
there is no claim data?
We're hearing a lot of background noise. Could you repeat the question, please?
Oh, sure, sorry. What about new providers that are coming in? What are we going to they're a new provider?
Do you mean an individual provider within your clinic or a new contract?
A new provider, a new contracted provider, individual provider.
So since we assign patients at the clinic level, a new provider in an already contracted clinic setting will not impact this. We would want to talk about how we might adjust your capacity limit for the clinic if a new provider gets added. Was that your question?
No, my question was for an individual provider. So new provider coming into the health plan of San Mateo, contracted on their own, just starting fresh. So there is no claim data from the previous year.
Okay. So for a brand new contract setup, they likely won't be able to participate in the benchmark program for that year because it is an annual program.
Okay.
Did that answer your question?
Yeah, I did. Thank you.
Okay. Were there any other questions on this?
Yeah, Katie, this is Evelyn from Ravenswood. For these reports, what's the data lag for these reports? So if the dates of service were in March, for example, up through March for this report, when would we get this report?
So we're going to share this information in as real time as possible. So this example report here would be posted to eReports by April 2nd, and it would have any claims that we've received for January, February, and March so far that year. So if you think that a claim has been submitted and is not reflected by that date, then we should be in touch about that. But if you think the service has been provided and we just don't have the claim yet, then you can hold off and wait until the following month's report to see if it shows up there. Because again, in addition to this summary level progress report, you'll also get the patient level detail. So you'll be able to go in and see that, okay, for this patient, we know the service was provided. HPSM just doesn't have the claim yet. And once we have the claim, that will get reflected in those reports.
Great, thank you.
Right. So, and then the other piece of this is that the final payment amount and final quality, total quality score will get calculated in April following the program year. And that's so that we can 3 months.
Dr. Valdez?
Could I just ask everyone to check your phones one more time, to please put them on mute if you're not asking a question. All right, so did that answer your question, Evelyn?
Yes, thank you.
Okay. And we'll have more time for questions at the end as well. All right, so here are several reports that you will start to receive. So if I'm a provider participating in the program, in order to actually improve my performance, I'll have a number of these tools at my disposal. The first one I'm going to use is the member detail report, which will let me actually see, based on the progress report. So if we look at cervical cancer screening, the member level report will show you exactly which of the patients assigned to you fall into that 52 count in the denominator, and who's eligible for cervical cancer screening, and also who is counted in the 22 in the numerator. These reports will also have the patient contact information that we have on file, and that's so that your office staff can conduct patient outreach and get them in for those preventive services. And it will look very similar to the member level report for P4P that's available today. So again, you can go into eReports right now and look at how your clinic is doing under the fee-for-service program at the patient level. Report number 2 is what we just looked at, and that's the monthly progress report. Report number 3 is the year-end version of report number 2. So this will come out in April following the program year. And again, we're allowing 3 months of a claims lag to submit claims for benchmark performance calculation. So we give clinics as much credit as possible. So the cutoff date for claim submission for the 2018 program year is March 31st, 2019. And then in April, that is when the final quality score and bonus payment will be calculated. And finally, report number 4 is the annual payment report, and that is simply the financial summary of what you earned that year based on performance. Okay, so now we're going to go over the full measure set and the quality thresholds for this year. So this first slide is only several of the measures. We had to break it up into a few slides. The first column is the performance measure name. The second is the measure source. So again, you can see that many of them are the NCQA HEDIS measures, and several of them are HPSM specific. And then the third column is the full credit benchmark. So that's the quality threshold for getting full credit for those measures. And if it's a HEDIS measure, just as a reminder, we're using the 75th percentile. The fourth column is the partial credit benchmark. And again, if it's HEDIS, we're using the 50th percentile for 2017 rates. The fifth column is the full credit quality score. So that's what you will earn once that full credit quality threshold has been reached. And then the last column is the partial credit quality score, and that's what you will earn if you fall somewhere between the partial and full credit quality threshold. Okay. So here are the diabetes measures. It's the same breakdown of the table in the last slide. The first measure here, the comprehensive diabetes care, is an HPSM-specific measure, and that encompasses providing all 4 of the services listed below, so that at least 50% of your assigned diabetic population throughout the year have had all 4 of those. And it has a higher full credit quality score, and that's because it's a bit more extensive than the individual measures alone. And again, these slides will be posted. The full benchmarks and scoring will be in our program guidelines, and those should be available very soon. And then finally, this is the remainder of the measure set for this year. And I'm just going to pause to give everyone a chance to look over this table before we move on. Are there any questions on how this is outlined or the information? Okay. All right, so now we're just going to give a few sample measure definitions so you can familiarize yourselves with how this will look in the program guidelines. So the first one is for depression screening and follow-up. And for this baseline year, it's a health plan specific benchmark, and it's also a targeted measure for the health plan. So the guidelines will show the patient eligibility. So for this one, it's anyone 12 years old and up. And largely, patient eligibility is broken down by either age, gender, or diagnosis category. So again, for example, if they are diagnosed with diabetes, they would be eligible for those services. And then it'll show you the full and partial credit benchmarks and also how the measure is defined. So who will get counted in the numerator to get you over those quality thresholds. Also, the program guidelines will have the full list of procedure codes and diagnosis codes for each of the measures. And here is another sample, and this is the comprehensive diabetes care measure that we just went over. And again, it's a combination of the HbA1c test, the eye exam, diabetic blood pressure reading, and medical attention for nephropathy. And for this year, since it's a baseline year, we're setting full credit at 50% of the population getting all four of those, and 40% is the partial credit benchmark. All right, and then just providing one more example of what that measure definition will look like in the guidelines. Okay, so now we're going to talk about the payment methodology. So based on some feedback that we've been receiving from providers about what payment schedule would work best for their practice, we've developed two options for the payment structure under the benchmark program. And as with anything, there are pros and cons to each option. So for the annual payment option, you would receive one lump sum bonus payment after the cutoff for encounter submission. So these payments would go out in April following the program year. The drawback here is that there would be a lag time for that payment, but you also wouldn't have to worry about any reconciliation because the total payment would be based on your actual annual performance calculation. For the monthly payment option, you'd receive a portion of the total potential that you could earn each month through capitation, and that can help with cash flow throughout the year. But for this option, there would be a year-end reconciliation, and this would also occur in April following the program year. So under this structure, there would be that risk based on how many of the quality benchmarks have been met that some of those funds may need to be paid back. And again, it will depend on what that final quality score comes out to be. And for both payment options, we're looking to add an additional bonus for any clinic that reaches all of the full credit quality benchmarks they're assigned for that year. Are there any questions about that? So what we'll likely do after today's webinar is we'll reach out to the participants and other providers, and we'll gauge which one of these seems to make the most sense. And then the goal is to have one payment schedule for this program that we'll decide on by July, so everyone will be notified once that decision has been made. Okay? So under either payment schedule, this is how the final earned amount will be calculated. We're going to take the average number of patients continuously assigned to your clinic for at least 9 months out of the calendar year, multiply that by 12, and that will equal the average member months, similar to the example we went over in that sample progress report. So then that will get multiplied by your total quality score. And the quality score is going to be the average of all of the quality points earned, also as demonstrated in the sample progress report. And then that will equal the member points. And then the total member points will get multiplied by the dollar amount per member per month, and that will equal the total payment. So as of right now, we don't know what that dollar per member per month amount is going to be, and we'll know that after we have the decision from providers about who will participate in Track 3 by July. And the reason for that is because there's that fixed pool of performance dollars, and depending on how many members are covered by the program, that will help determine that dollar per member per month. But again, the idea here is that the payment structure under this program is set up so that the earned potential is higher than what you would have earned under the fee-for-service program. And again, we're also looking to build in that additional bonus at the year end if for any clinic that meets all of the full credit quality benchmarks. Are there any questions about that? Okay.
Dee, sorry, the additional bonus is given in December, but for the others who are doing their 1 year, they're waiting till April?
No, the additional bonus would also come out in April because it will be calculated based on that final quality score, and we're giving that 3-month claims lag time so we get as many encounters to count towards the quality thresholds as possible.
Okay. Thank you.
Yep. And that would be under either of those payment schedules. So even under the monthly schedule, that final calculation will happen in April following the calendar year. Okay, so for some next steps, in the next few weeks, you're going to get the final contract amendment from us, and hopefully you already received the preview of that, which was the template that was sent out in early April. And all of our primary care Medi-Cal clinics will select payment tracks 1, 2, or 3. And a reminder that this program would be under Track 3 for the Benchmark P4P program. We're going to have additional information on that payment structure and the final schedule for the program. And we'll talk about that in detail with all of the clinics that choose Track 3. And soon we'll have the full Benchmark P4P program guidelines posted on the website along with the new progress reports in e-reports. Okay. So we've reached the end of the slide deck, so now we want to open it up for discussion and try to answer any questions that we can today. And again, if you have any follow-up questions that you maybe don't want to ask in the larger group setting, please feel free to email us after today's webinar, and you're going to hear from us again on all of the contract amendment discussions very soon. So with that, I will open it up for any questions anyone would like to ask on any of the things that we just covered.
Katie, what is the difference between Track 2 and 3 again? Can we go back to that screen?
Sure.
Thank you.
So the difference between Track 2 and 3 really is the P4P program that the clinic would participate in. So under Track 2, it's the fee-for-service P4P program like what we have today. And then Track 3 would be the benchmark program, which is what we just reviewed.
So
thank you.
Example, yeah, and this is, again, just to kind of recap if folks haven't been on some of our previous webinars, one example here is, say, for depression screening. Under the fee-for-service pay-for-performance model there in Track 2, you'd get that $30 payment for us based on the claim every time you do a depression screening. If you're on Track 3, that benchmark payment is really, again, as Katie started kind of at the beginning, looking at the whole person and the whole panel. So instead of having the incentive tied to a single service, it would be if you hit that 75% mark for having done the depression screening for at least 75% of your eligible patients. And slightly larger incentives are earnable under that Track 3 model.
It was founded in 1871 by artists, writers, and community leaders.
And I think we might have somebody who's gone off of mute. But does that help with the question?
Yes, thank you.
Great.
Okay. And we are building in the continuous assignment criteria to the benchmark program, and that's also so that we are not penalizing anyone for patients who haven't been assigned to you for 9 months at least out of the year. So in the monthly reports that you're going to get, it's going to have your current assigned panel and we won't know until the end of the year who of that panel have been assigned for at least 9 of those months. If anyone's been assigned to you since January, then we would know in October that they're going to get counted, but it will just depend on that continuous assignment time frame as well.
Katie, it's Evelyn again. Thank you for this. When do we have to select the measures set? Is it with the contract amendment by June 15th, or is that a separate?
Yes, so it will be with the contract amendment. So as part of the amendment, there's an attachment that has the full measure list, and we'll talk with you about which of those 3 your clinic would be assigned based on the patient population age range, and then additionally you'll choose those 4 other measures to get to 7 for this year.
Great, thanks.
All right, are there any other questions?
Yeah, it's Evelyn again. Do you guys anticipate providing any baseline reports on baseline performance on all of the measures to assist us with selecting the measure set? Is that something that's possible to do?
So we are working on building the progress reports for all clinics now. I can't guarantee that they'll come out before July. The goal here really is to focus on measures that you'd like to improve on as a clinic. I know that there is the financial piece to it, so the selection, may be based off of that, but truly the goal is improvement. And if the reports are available, it's likely that we could share them in advance. I'm not sure if they'll be ready by then, before the July 1 date. But again, really the goal is to focus on measures that within your clinic you'd like to improve on.
Sure. I think it would be really helpful in the selection of measures so we can find ones that we are able to both balance the financial risk and make the improvements on and make informed decisions about selecting measures that way, because the data source is so different from claims than our self-reported data. It would be a great assistance if it is possible to get that data ahead of time.
Yep.
Thank you.
Can you clarify again the start date of when you're going to extract?
Sorry, I'm not sure what do you mean the start date?
Is it going to start January of 2018 for the data that you're going to be collecting?
Yeah, I think probably, because I think we need to have the 9 months of continuous assignment for this year.
Okay.
Yeah.
Will you let us know that?
Yes, we will. It'll be in the program guidelines for this year.
Okay, and I'm sorry I logged in late. What was the track 1? You mentioned track 2 and 3. What was track 1?
Sure. So track 1 is the fee-for-service option, and it includes fee-for-service for the base payment as well as fee-for-service for the P4P payments. And it's really geared towards smaller clinics that have a small volume of HPSM members assigned.
Okay. And will that have a larger incentive as well as the track 3, or?
It won't. Track 3 is the benchmark P4P program, and that is where we've built in the additional performance dollars.
I see. Got it. Thank you.
Yeah, both track 2 and track 3 are on the capitated model. So for practices that either have capitation established today or would like to move to that.
All right.
What should be the minimal amount of patients for capitation level?
So the minimum for the denominator is 30 patients. So, and that's also, again, that's so that we have enough in the sample size so that there's not that wide variation in terms of performance. Does that answer your question?
Yes, but I mean the number of patients assigned to the provider. For example, I'm a solo provider, and I have maybe 50 patients total.
Okay.
So what model is good for me? for example?
Sure, yeah. So for this year, we are not setting a minimum threshold for capitation for the payment tracks, but by the end of phase 1, so by January of 2020, we will have a minimum threshold for those payment tracks, and it will at least be 30. If more than that makes sense, we'll figure that out. We're going to have additional conversations about this internally and with all of you prior to the phase 2 rollout, but there will be a minimum threshold at that point. But for this year, we have not built that in.
And what is the capitation rate?
Based on aid code. And so, yeah, that is a rate that we could, I think our tables we could maybe share separately.
Yep. Yeah. So it really depends on, the rate you receive depends on, say, the age of the member, and then how they're sort of designated by the state as a little bit of their acuity. So if they're a senior, they have a disability status, for example, that rate's be different from someone of the same age with without any disability, right?
Mm. So it's not defined yet. Completely understand, yeah?
No, it is defined. It's just it varies by individual member, essentially. So you're getting paid currently. If you had capitation, you're getting paid. Every member assigned to you has a slightly different capitation rate depending on the sort of the age, the gender, and potentially the other status of that of that member. So you're getting one monthly payment, but that's actually broken down of a sum of your total membership. So if your panel is different from, say, your neighboring provider, you might have you have the same number of members because your panel makeup might be different. You might be receiving separate different capitation payments.
Yeah, and if you or anyone else on the line would like to learn more about our capitation model, I'd recommend that you reach out to your provider services representative who can share what that cap table is, and they can share the exact rates for each category of member.
Okay, thank you.
And then also, if you have e-reports, there is a capitation register that will give you that breakdown by member and how much you're being paid each month if you're on capitation.
I have a follow-on to that question, or the beginning of it, which is, we've had trouble with utilization by assigned patients. And so getting to some of those thresholds might be challenging. I'm wondering if the health plan could be a little more helpful in helping us to, reach out to patients who haven't come, or to sort of help us see whether they might be going somewhere else, and thus, we could reach out to them and just sort of settle whether they're going to be assigned to us or not.
Absolutely. That's a very good question. So right now in e-reports, there's a new report called the Active Engagement Report. And the first version of that came out in March, so there should be 2 months' worth of data there, and there will be a new one posted next week. All of these will come out monthly on the second day of every month, so you'll get a new report for that on May 2nd. And within that report, it does show you your active panel as of the first of the month, and it will tell you if those patients have had any primary care visit within 12 months up to the report run date, and it will tell you whether that visit was at your clinic or somewhere else. So you will have that information. It's new, and that's
Wonderful.
What we'll cover. Sorry?
Wonderful. Go ahead.
Okay, so that's what we're going to, and we'll cover, again, the use of those reports and how to filter for various things on a webinar that we'll have sometime in May. And we can also talk individually, and you can reach out to your provider service representative to set up some time to go over the reports as well, and we can go over them with your office staff since they are new and there's a lot of information in them, and that's by design. And so there are specific things that you will hopefully, get out of those new reports. And then on top of that, we're working on a patient reassignment process here. And you'll receive an announcement about that probably by later today, actually. So there are 2 lists in e-reports. And what we're doing is we're starting by looking at patients that have 0 visits at their assigned clinic and at least 2 consecutive visits at a non-assigned clinic, and they're only going to the non-assigned clinic for primary care. And that's over a 15-month look back. So what we're going to do is we'll reach out the health plan will reach out to those members, and it's an opt-out. So unless they tell us that they don't want to be reassigned, we're going to go ahead and reassign them to the panel that we are. To the clinic that we're going to. Okay, great.
Yeah.
There are some contingencies for that reassignment to occur. The provider has to be accepting patients. There has to be capacity within their panel, and they, of course, have to be contracted with the health plan. But if all of those things line up, which we have the lists for, then within the next 4 to 6 weeks, the first wave of that reassignment will occur, and we're going to do that on an ongoing basis going forward.
That's great. I want to let you know about a pilot we're doing with San Francisco Health Plan that you might want to consider, which is when their call center gets a call from someone who hasn't been to us, they're going to do a 3-way with us to get an appointment scheduled for the IHA or to kind of help them, you know, figure out whether they're really going to come to us or they're going to stay where they're actually going. And that's going to be a pilot at our main site.
Interesting.
Yeah. And sorry, who is that speaking?
Yeah.
This is Patty Kaplan from Mission Neighborhood.
Oh, great. Hi, Patty. Thank you for sharing that.
Yeah, maybe we can follow up with you on that after today.
Yeah. The report you talked about, active engagement, is that on the portal or what?
Yep, it's on the eReports portal.
Great.
I think we're sending that link around to everybody, if it's not already in the last email, in the follow-up to this webinar as well.
Yep. Yeah, the link to eReports is in this slide deck. It's also on our website, and you can also just send any of us an email, and we can send it over to you.
Great.
And again, we can get as many staff set up with a login. We do have to do individual logins. We can't have a single login for each clinic, but however many team members you'd like to have with logins, we'd be more than happy to set them up.
Okay,
We're also
great.
looking at doing a tiered login system because there is financial information right now in eReports, and so very soon we'll have an option for full access to eReports, which will include the capitation roster that has the payment information, and it'll also, in future months, it'll also have the P4P payment summary information, and then we'll have a level 1 access, limited access, that will just have these patient lists so that staff can do outreach. And actually right now, as of last week, I think, there's actually a 2017 P4P payment summary in eReports, so all of you should have a copy of that available to you. And really what it does is just by measure, it summarizes for every month of the year. We looked at it by date of service that the payment was made for, so it's from January to December of 2017, and then we sum it up by measure and then the total payment that you received for 2017 P4P dates of service, and that's available right now.
It would be helpful to know about the different levels of permissions in the portal because we actually track who gets an account and the, the kind of level of rights. So if somebody could share that, that would be helpful.
Sure.
Yeah, and today there are just 2 levels of access to those reports. So one is for access to all reports, which includes financial data. There's also a level of access that includes non-financial reports only.
Okay.
When you request a new login setup, you can let us know which level you would like that setup to be for.
Yeah. Okay.
Basically, it's either including financial or not. Sorry, go ahead.
Okay. Is there an authorization form that the individual has to fill out to get access?
We don't have a form right now. We likely will soon, but if we have an email sign-off that's documented from you or whoever is at a similar level within each of the clinics, then that will get counted as allowing permission for that right now.
We do confirm access requests, though, with a confirmed contact at the clinic. So if we get a request from someone that we don't know for access at a clinic, we would certainly escalate that to the main clinic contact point for the plan.
Yep. Great. Wonderful. Thank you.
All right. Are there any other questions for today? Okay. Well, I will just go back to this final slide with our contact information so that you can send us any questions that you might think of after the call. And again, you'll hear from us soon to talk more about those contract amendments and getting that all finalized. All right, so with that, we will give everyone 10 minutes back in their day. Thank you all for participating, and you'll hear from us very soon.
Thank you.
Thanks, everyone. Bye.